Good evening, everybody. It's my privilege to be with you. I'm grateful John didn't completely read my bio because it sort of reads like an obit, or someone who can't hold on to their job, onto a job. It's a privilege to be with you because community hospitals, from my perspective, is really the heart of the healthcare system in Massachusetts. For me, it's community hospitals, it's our federally qualified health centers, which is really where we should be getting the bulk of our care, along with our primary care physicians' offices, and then using some of the best that Massachusetts also has, which is our academic medical centers and our teaching hospitals for that very high-end specialty services that we may need. So I stand here in front of you to say that one of the reasons when I was thrilled to receive the invitation was to really say that publicly, that community hospitals and healthcare is changing. We have to be nimble. It's really hard to have our structures nimble, but it is really important for us to be nimble. But community hospitals and the changes that have happened here in Needham, to me, really presents the opportunity as we go through these challenges. So to John, what I would say to the board and the trustees and the people who are in this community, you are fortunate to have someone at the helm of this hospital as John. The hospital is strong financially. It is strong from a quality perspective. It's strong from its relationship with an academic medical center. And if you don't know that, then hear it from the Secretary of Health and Human Services. And I don't say it because I'm here. I don't say it everywhere I go, but it is true about this hospital embedded in this community. That's one. Two, I have to give a little shout out to my good friend Steve Walsh, who as he becomes the president and CEO of the Mass Hospital Association, he comes from a complete understanding of the needs, the opportunities, the challenges of community hospitals. And I know he will not forget that in his journey as the Mass Hospital Association. I look so forward to working with you in your new role, in your current role as you transition to your new role. And for many of us, we know him also from his days as a legislator and his work in healthcare. So I can't think of a better person coming into the shoes of the Mass Hospital, whatever the other H is, the Mass Hospital. I still think it was the Mass Hospital Association at a time of extraordinary opportunity and challenges. And I don't minimize the challenges. And my good friend, the chair of the Mental Health and Substance Use Committee, as I fall apart here, Denise Garlick, who is such a passionate advocate for health care, for nursing, for quality, as we go through these journeys together. So with that, now I can't compete with my good friend, that 6'6" guy who's the governor of the Commonwealth of Massachusetts, who was raised right down the street here, who has told me, and I'm sure if any of you have run into him, that every time he fell when he was a kid, he must be really clumsy. He ended up at the Glover Hospital in the emergency room having, lots of stitches. He doesn't look like a guy who has a lot of stitches, but maybe he does in that 6'6" frame. But I'm sure that the other Baker boys were also in the emergency room. And he knows how important this hospital is to this community. But what I can tell you from actually personal experience, and when I was here last Friday, I shared a little bit of a story of a very dear, one of my closest friends on earth. I've known her since I was a graduate student many, many years ago. And she had the choice of a surgical procedure. I had to call her after I was here she had to remind me exactly what the surgical procedure was, of actually going into town to Beth Israel Deaconess Medical Center or having the surgical procedure here in Needham. And she chose to have the surgical procedure here in Needham because she works in this community and wanted to be closer to her colleagues, her friends, and have it easier for people to visit her, and the best of the care that the Beth Israel system had to offer her. My husband and I, and Ted Ladd knows my husband, so Bradley and I came out to visit our dear friend twice while she was here. And what I can tell you it's an N of 1, but what I can tell you from the 2 times that I came to visit, the extraordinary care, the nursing care that she got here, her surgery was perfect. She's wonderful. and how she has said that if she ever needed to have care again, this is where she would come. So I tell you that, again, as an N of one, but my own experience when I came here to visit of someone who's very, very dear to me. So one of the reasons that community hospitals are so important is because not only do they provide, they're in and from community, responsive to the needs of community, they are not in competition with our academic medical centers, but they are the place where we should go for our care, rather than going into academic medical centers. And the role of academic medical centers is really for that tertiary and quaternary care that we may need. And the strength of this system in Beth Israel, and I should in all full disclosure tell you that I get my care within the Beth Israel system. So while I'm completely objective as Secretary of Health and Human Services, maybe I'm a little biased, because this is where I've gotten my care for so many years. But it's the complementary nature of this relationship that strengthens this hospital system. But in my day job, so yes, this is what half of state government looks like. Here it is. I tell the governor on every day it's the best half of state government because it's where 1 in 4 residents of the Commonwealth touch directly some part of the enterprise that I am responsible for. And while we cannot solve, it is extraordinarily humbling. It's a privilege to be a public servant, but it's also extraordinarily humbling because even when you're responsible for half the state budget and this huge enterprise in front of you, you can't resolve every issue that comes to you or every societal condition or problem. But you can treat people with dignity and respect, whether it's an individual, a family, a community, a hospital system. And that is one of the reasons when Governor Baker, so this is really a true story, the morning after the election, I get a text from the incoming governor of the Commonwealth of Massachusetts. This is apparently how we communicate now in this world. And I looked at it, and I thought it was, well, of course I'd be on his transition team. I've known him for 20, 30 years in various capacities, so of course I'd be on his transition team. And then I looked at it a little closer and realized, I'm actually thinking maybe this is like an employment kind of a thing. And I actually showed it to my husband just to make sure I hadn't overread into the text message. And my husband said, whoa, I think you're in for a ride. And actually Bradley said, maybe teaching health and mental health policy is a better place to be right now at Boston College than actually trying to do health and mental health policy in the Commonwealth of Massachusetts. But I have to tell you, it's an extraordinary privilege. The governor, as you all know, is a moderate Republican in a very Democratic state. I'm his independent in his bipartisan cabinet, and anybody who knows me would probably say that about me. I tell it to him straight. I tell it to him in the way that I think is the most respectful and the best path for us. Because as a social worker, we're taught to listen hard and to listen to all of the different perspectives in order to try to find a path. So let me talk just a minute, and I do want to take your questions because that's one of the reasons why I love to come out to hear your truths, your worry. I'm a worrier, so we can worry together. But let me do a little bit on the national scene and then come closer to home. So today, I know many of you may want to celebrate on the defeat, or actually on the decision by the Senate to not put the Graham-Cassidy-Johnson-Heller amendment for a vote, because there were 3 very courageous Republican senators who basically said this is not right in terms of either a process or for their states. But what I would tell you is we dodged a bullet. I need to find a better metaphor because I don't believe in guns, but that's a different subject. But we dodged a bullet because I got to tell you, this is going to be back next year. It does provide an extraordinary opportunity for Congress to try to model what we do in the Commonwealth of Massachusetts, which is bipartisanship. We sit at the table, Republicans, Democrats, and the biggest party of all, which is us, independents, to try to resolve some of our thorniest issues. We sit at the table and we discuss things respectfully. It's a civil discourse. This governor will not engage in political rhetoric. We do not refer to the Affordable Care Act as Obamacare, not respect a singular, extraordinary act by a president, but to not engage in the rhetoric of what, when people say Obamacare, what they really mean, which is sort of something bad. So we engage in the work that we do in a very bipartisan way. I'm the governor's, if you've seen some of the governor's letters to Congress or his congressional testimony, and if you find it boring, you can blame me. I am his ghostwriter. I will just come out of the closet right now. But it is about facts. It is about what Congress needs to do to stabilize insurance markets, to ensure that we remain the highest insurance coverage of any state in the United States. And it is from having 98% of our residents having health care coverage that we can then have the more difficult conversations around affordability, access, quality, and disparities, and everything else in between, right? I'd much rather start having those conversations from a point of having almost all of our citizens in this great state with coverage than in some other states that have almost 20% of their populations without any health care coverage. Now, I know health care coverage does not equate necessarily to access and availability, but it's a much better place for us to be having these conversations. In our state, we can talk about health from what health stands for, which is physical, behavioral, and oral health, not just physical. And we know there's so much more we need to do here, but we can have those conversations. One of the positives, and if I'm a little singularly focused on what's been happening in Congress, was because of what would have happened if it had passed. If it had passed in the Senate, it would have passed in the House and would have been signed into law by the president. Wherever you come down on the Affordable Care Act, if this had passed, it would have been a $2.2 billion loss. I know, I'm only talking billions and millions anymore. A $2.2 billion loss in revenues to the Commonwealth of Massachusetts, starting in 2020. And starting in 2020, it would have been $500 million. And it goes down very quickly after that. Just that in and of itself, I told the governor I wasn't going to get out of bed if it actually passed. He actually told me he could find me. $2.2 billion. Almost 600,000 people in Massachusetts would have either lost health care coverage or would have seen double-digit increases in their health care coverage starting in 2020. That's what was at risk. And in the spring, as the Graham-Cassidy bill was sort of working its way, if you would, through Congress, Governor Baker engaged in a very bipartisan effort across state lines with 14 other governors. My job was to basically scare the bejesus out of my counterpart or the governor's healthcare advisor in that state to set up a conversation. Apparently I do that quite well. And the governor would then have a conversation with that governor. It was Democratic governors, it was Republican governors, there's an independent governor. It could be states that expanded, states that didn't expand, to see if we could try to have some bipartisan conversations about what we could do about health care in the United States. I actually do believe that work of those governors, along with 3 very courageous Republican senators, sort of paused this button right now and creates an opportunity for us to engage in a different conversation. Literally, a week ago last Sunday morning, so the good news for all of you is your tax dollars at work. I have no life. Literally, a week ago last Sunday morning, I was making technical edits to Senator Lamar Alexander and Senator Murray's compromise bipartisan bill. It was a very good bill. It would have stabilized insurance markets, bought some time, if you would, for people to engage in a different conversation. By Monday, it was completely dead because of this sort of oxygen being sucked into the Graham-Cassidy bill. I was actually sort of checking my emails, sorry. And it looks like there's a chance for the Senator Alexander's bill to come back up, and we will see. So some of you may want to celebrate. I know, he's like, all right, go do your job. We're counting on you. 37,000 square feet. No pressure. But that is part of the message we need to deliver together to Congress is around a bipartisan conversation, and that health care coverage is a strong base to start on the some of the more complicated conversations. Closer to home, Massachusetts has been leading in the healthcare space, and we've been working at it for years. This is not a, if any of you have ever been involved in legislation, as two of my friends in this room know well, it's complicated. And you never, unless it's naming a building, you never get it right on the first time. And you have to keep coming back to fix it, because healthcare is changing, the economy is changing, what we know has changed. Sometimes what you think is the right path, you have to come back and sit at the table and tweak it. And we engage in that in Massachusetts. So for 11 years, we've been innovating healthcare. Not all of it great. We know some of the threats to some of the community hospitals out there. They may or may not survive. We know that mergers, sort of make the Health Policy Commission sort of squishy on occasion. That's my technical term at this hour of the night. But these are the conversations we need to have. We know that nurses often feel tremendous pressures on them to do more with less. But these are the conversations that we need to have. So we're having them in Massachusetts. And part of it is around Medicaid. And I'll just end on this note. Medicaid is extraordinary. Since I'm half of the state budget, Medicaid is 40% of the state budget. It's an extraordinarily important health care plus program for just about 30% of our population. It's about 1.8, 1.9 million people have Medicaid as their primary health care coverage in our state. It is a good benefit. It's a strong benefit. We believe in benefits in this state. It's also been on a pretty unsustainable path because it's just the cost every year, it just grows and grows and grows and takes up more of the state budget. I'm a social worker. I didn't come back to the state to slice and dice our way out of a Medicaid program. But I am committed to working with the legislature and with all of you on finding a more sustainable path. And with that, I applaud the BI system for joining with us in the Commonwealth as one of our partners, one of our 17 partners in trying to restructure the Medicaid program. I'm going to give you a new name, if you haven't heard this name on the boards, called Accountable Care Organizations, basically really giving sort of the care responsibility, the whole care of a population, to primary care and seeing if we can really manage people's care in a different way. And if we do that right, we will manage costs. I don't start with the managing costs. I start with the thing of managing care. If we manage care well for people so they don't keep coming back to emergency rooms, we can have people not use emergency rooms for primary care. We really can do better for people on the Medicaid program. And if we do that, we will put Mass Health back on a sustainable path. So let me end on that. I know it's a little wonky. My former students don't think I sound like a social worker anymore. What I will tell you is this is my third return to public service. I think when I stepped down as being Commissioner of Mental Health after 7 years, people thought, she's gone, she's like a bad penny, she's really gone. But it is our administration's commitment to work with all of you on the thorny issues of health care, because it's by all of us sitting in the rooms together, we will come out for the very best possible outcomes for the people we care about. So thank you for having me. I think we're going to do some questions. As long as you don't throw tomatoes, anything you have to ask. So thank you so very much. You on?
Hopefully this is working.
Yep.
So thank you very much, Secretary Sudders. So we do have time now for a Q&A session. We're going to have a few people walking around the room with microphones. So please raise your hands, and I want to, once I call on you, wait for the microphone to get there. And I'm going to just kick us off to get us going. John earlier brought up the opioid crisis, which is a real national and statewide and regional-wide scourge. The Department of Health and Human Services has announced a 5-point strategy for attacking the crisis, which includes access to treatment, recovery services, strengthening our understanding of the epidemic, and providing cutting-edge research on pain and addiction, to name a few. What tactics would you suggest for a community like ours, a hospital like ours, to participate in combating?
Thank you. Thank you for that. So I usually refer to the question and answer time as the stump the secretary moment. So the governor, as you know, when he was campaigning across the Commonwealth, someone would come up to him and talk to him about their family member or loved one who is suffering from addictions. So when he became governor, he asked me to chair a working group and to come up with a blueprint for Massachusetts. He gave me 2.5 months to do it. Welcome back to the Commonwealth. And we put together a public health approach of prevention, intervention, treatment, and recovery. 65 recommendations. It was a very broad group of people with very different perspectives. I've sometimes said that my group work, my rusty group work skills never came more in handy than keeping the group together. And we've been rolling it out. So the first thing is to remember that addictions, I'm saying it to a group of people who I probably don't need to say this to, addictions are a disease. They're a chronically relapsing disease. We need to embrace the person who's struggling with addictions and walk in with them and not away from them. And it is a long journey of recovery. That is one. Two, in your emergency rooms, we've done a lot in Massachusetts to really bring down the prescription of opioids. One of the things I would encourage, and I really look to the medical profession and others to help identify alternatives to pain management other than scripts of opioids. There are some good alternatives out there. There's some cost factors, but I'd really encourage your hospital to really start having internally a conversation of the treatment of addictions. Behind addictions is often anxiety or depression. That's that integration of behavioral health. But it is an epidemic. Needham has been spared in terms of overdose deaths, but I will tell you, addiction touches every community in the Commonwealth of Massachusetts. We are all in this administration. But if nothing else, just having within the hospital conversations around being open to addictions, as we are open now around, I mean, when I was a little girl, when I was young, I remember polio still existed, and remember cancer, we whispered the word cancer, and it was a death sentence, and we know cancer is now treatable, right? And people have good lives after cancer treatment. And addictions is the same way, and we really need to talk about addictions for what it is, which is a disease. That'd be one. Yes, sir.
Yes, right here.
Hi.
I don't mean to put you on the spot.
Feel free. Everybody else does.
As Paul Levy introduced me to Charlie Baker at an event here some years ago as being the one who caused him to be successful because he dropped out of my course at MIT. I'll give you 5 questions. Pick and choose which ones you want to answer.
At my age, you're assuming I'm going to remember all 5.
No, they're simple ones. Demographics. Eastern Massachusetts particularly, but Massachusetts and New England in general, is undergoing a dramatic tilting of the population to the elderly, defined as 50 and over.
Mm-hmm.
And therefore, without any question and expectation of higher utilization, both acute but also for chronic long-term care, and hence a major impact on mass health. And I'm just curious as to what planning has gone into the both financial and structural issue there.
I like that one.
I think you should take it first.
Can I take?
Let me throw these at you and you can answer. Is there a plan to deal with the possibility that irrespective of any votes that did not occur, that the federal government may choose alternative methods to reduce the funding for Medicaid?
I think, why don't we, I'm sorry to cut you off, but why don't we do the choice of one of those two, just so we get enough questions?
Sure. So in response, so I'm the oldest person in the governor's cabinet, and I'm proud of it. The governor this year signed an executive order creating a council on we've renamed it Optimal Aging. It's co-chaired by 2 social workers. I'm one of them. The other is Eileen Connors, the wife of Jack Connors. Eileen is a social worker, and we are putting together a blueprint for the governor to think about what we need to do across the Commonwealth to really support optimal aging, healthy aging. Some people refer to as aging in place, and what kinds of supports we can localize, we can maximize local solutions, as well as some things we need to do in the state, everything from housing solutions and taking down a whole lot of regulatory barriers that apparently have created for a number of years in my secretariat that we will sort of streamline to make it easier for people to live at home with supports or live in assisted living with nursing supports or whatever their care needs. So you could expect something from us probably November, December. We're really thrilled in Massachusetts to have, so I have 2 secretaries, 9 commissioners, and 1 director, you go figure out the org chart, who report to me. And one of them is an extraordinary woman who's leading elder affairs, and that is Alice Bonner, who is just this amazing woman to really help us on understanding what we need to do to prepare as a Commonwealth for what some people refer to as the gray tsunami. I think of it, what do we do to support all of us as we age gracefully? So that's sort of my answer to that one. Yep. And I'm happy to send it out to the hospitals.
So back there.
Yeah.
Question relative to the budget. 10 years ago, what % of the state budget would Medicaid occupy?
10 years ago. So 10 years ago, it was about 24, 26, about 25% of the budget. And now it's 40. And when I came back into public service in January of 2015, I saw a trajectory of the Mass Health budget that had it about $18 billion in 2017 at the trajectory it was going on. And it's about $16 billion right now, just over $16 billion. So we've done a lot to manage the program in a way that you run an insurance program, ensuring that we have strong program integrity in place and that people who are eligible for Medicaid have Medicaid. So we're doing lots around what we refer to as the internal control part, which really was not a priority of the prior administration. The prior administration was very focused on enrollment, and I completely understand that. So we're about enrollment, eligibility, and program integrity to really manage the Mass Health program. But we also understood we really needed to restructure it going forward, which is why at the end of the President Obama's administration, we received a federal waiver, they're called waivers, for Medicaid programs. So I secured a $54.2 billion 5-year waiver for the Commonwealth to secure the safety. I know, it's ridiculous, I'm only talking billions and millions. The safety net care pool for Massachusetts, which is very important, as well as really expanding addiction services starting in January of this year. And that's secure whatever happens in the next few years. So I'm looking forward to 2022 when we have to renegotiate that waiver. I'm hoping to be retired by then.
So wait, can I
Anybody
have
else?
one
One
more
more?
question? And I know you guys aren't that shy.
Oh, come on.
Come on.
Yeah.
Dr.
Okay.
Kemp,
Oh,
What do you think of the Medicare for All concept?
what do you think of the Medicare for All concept? Well, there's a, now that's putting her on the spot.
no, it's a fair question. So I have 2 responses to that. So it is actually, so this is politics. This is pure politics. So it was actually the Medicare for All conversation in Washington recently that actually completely ignited the Republican senators to push hard on Graham Cassidy. So there's a little part of me about the Medicare for All that I'm feeling rather sensitive about, because Graham Cassidy was dead. And it was my good friends sort of pushing Medicare for All that gave the Republican side of the Senate sort of a, see, if we don't do this, we're going to have Medicare for All. And it's just pure politics, and I know Steve would certainly understand what that means when you give somebody an issue that, even if it's not fact-based, just became sucked all the oxygen in the room. I think it's aspirational. It is, and maybe sometime we will have a single-payer system. It's impossible for me to see that right now. And if Vermont couldn't do it, which essentially had 90% of their population in one health plan, and they couldn't do it and passed legislation and then repealed it, it's really hard for me to see it in our state or nationwide. I'm not saying that some people shouldn't push that's where we should go in the long term. It's very hard for me to see from this system to a single payer. And quite frankly, Medicare is not a single payer system because you can buy into it, you can do things privately and the like. But that's a great question for me to end on. Thank you so very much for having me.